Welcome to Health in Veritas. I'm Harlan Krumholtz.
And I'm Howie Foreman. We're physicians and professors at Yale University, and we're trying to get closer to the truth about health and healthcare. We usually, once a month right now, we're aiming to have one episode without a guest. And so today we're in the studio together.
It's great to see you, Howie.
It is, and it's fun. I mean, it really has a very different feeling when we're together.
Yeah, summer session, students aren't around. It's hot outside.
It's hot outside, and so we're both in polo shirts as opposed to any type of dress uniform. Student tie, of course.
Tuxes, yeah.
Yes, the tuxes. But it gives us an opportunity to really cover a lot more hot topics.
Oh, my God. Every week we want to cover so many things, and we just don't have time.
We can't do it. So today, what do you got for us?
Well, let me give you a couple quick things. First of all, last week I was at Aspen Health.
I know you were. I
know
with all of our friends.
So indulgent. It's a beautiful scenery. There's a lot of smart people there, a lot of people from government. And you know what bugged me was almost everyone I ran into said, Howie really influenced me. He really made such a difference in my life. I hear that one more time. I was just going to.
There were a lot of friends there. And to be fair, a lot of those people were texting me and saying, I ran into so-and-so and they said hi. And it was very nice. Even though I wasn't there, I felt like people were including me.
I thought it was a great session. It was a good place to learn about what's going on in government. It's Ruth Katz, our friend, we had on a couple weeks ago, runs it. And anyway, it was a really great event. So anyway, I wanted to at least highlight that. This week is our first issue of JACC. It was known as the Journal of the American College of Cardiology. Actually, we're going to change the name just to JACC because people seem to just like to say JACC.
But there's not going to be a K in it. It's still going to be
JACC.
JACC.
Got it.
Yep. Congratulations.
Yeah.
I know. It's not. You haven't even officially started.
Well, so July 1st I'm supposed to start, but the first issue was out anyway. I just wanted to say to anyone on the podcast, you can take a look at the first issue. It's full of great science. It's got a great review of medical history, cardiovascular history with lessons for clinicians and researchers. It's got a great piece by Rohan Kara on artificial intelligence. The FDA commissioner came in and wrote a great piece about the relationship of FDA to cardiovascular care. And Eugene Braunwald, sort of the grandfather of cardiology also wrote a welcoming piece. And I have a piece that talks about the new era of JACC. And, one of the reasons I took on this position as being editor-in-chief of a major journal was maybe it's an opportunity to really reshape what medical publishing is going forward. And move it away from this very hierarchical model to one in which it's more about partnership, working together. We each have roles. We only have limited space within a journal. But I think we can be working more synergistically with the community in the common purpose of advancing global cardiovascular health and using the platform, not just the idea of pushing out issues, but using the platform in this way.
And you've just for our listeners been involved in publishing, not just from publishing your own papers for a long time. medRxiv, which is one of the open access.
Co-founded with Joe Ross.
Joe Ross, and that's been over 10 years now, right?
Maybe I think we might have started around 2019.
Okay,
it's actually really about 5 years,
okay.
and that's been a wonderful experience. I was an editor before.
Yeah,
we've talked a lot about data sharing and ethics within publishing. So this was
Journal Watch. You've been
I was editor of Journal Watch with New England Journal for a long time.
Yep.
But this was an opportunity to take a major journal, a family of 10 journals, and really try to see whether or not we could change it. Some of the things I wrote, I'd sent out a bunch of tweets and videos.
Yeah.
Said that transitions are opportunities full of possibilities, marking a juncture that combines an end and a beginning. And, the hope is that this is a moment to both honor the past and really shape the future. I wrote also that I thought that I envisioned JACC with its strengths as a transformative platform for building community, elevating strong science, influencing clinical practice, supporting career development, and improving patient outcomes. I mean, this is the thing, it's not just simply standing up on the mountain and letting authors, sort of make the trek up to see you, but actually seeing if we can work together holding hands to actually improve outcomes, make things better. So I'm real excited about it.
Does it feel more or less overwhelming right now that you've got one issue out?
Oh, my God. This has been overwhelming to the extent that really trying to think hard about how do you reshape medical publishing and bring together community people to do that. So I wouldn't say so much overwhelming as energizing, but there's been a lot
of work.
I
could tell that.
Yeah. So, hey, what's your first thing this week?
So I don't know, certain topics get me really excited, even if they're not in my primary field at all. Lenacapavir is an injectable HIV drug that is investigational and undergoing testing for both treatment and prevention of HIV infection. And there are a few things about this trial that just came out that stand out. And by the way, Gilead's the manufacturer of this. So there are I think there's 4 trials that are underway testing how effective this is in preventing HIV in at-risk individuals and then also in those who already have it. The first trial that completed enrollment, and now they did their immediate analysis and stopped the trial because the findings were so shocking. But this was done in cisgender women in sub-Saharan Africa. And by the way, adolescent girls and young women are 63% of all new HIV infections. Wow. And that high incidence is continuing despite the impressive improvements of the last decade. And the only way you're going to eradicate HIV is if you can get to this population in particular, which in America is not the population you think
rates
about.
Are still high in Africa?
Very high. Yeah. And across the world, over 500,000 people die of HIV every year. Wow. We have a couple of million.
You sort of think of it as under control, but...
Yeah, it's not. And a substantial part of infections in Africa and in the emerging world are untreated, even that exists. So there's a lot of work that needs to be done. Yeah. Lenacapavir is a twice-yearly injectable drug, and it was compared...
Sub-Q injection?
I believe that's the case. That's what it said, subcutaneous. And it was compared to the usual standard of Truvada, which is PrEP. PrEP is pre-exposure prophylaxis, which is widely available in the United States, and it has enormous protection for gay men in preventing HIV spread. Right, so you take Truvada, I believe, every day.
And why do you say gay men? Why wouldn't it be in anyone at risk?
Because nobody's done all the studies, and that was part of the reason why this was so important. And, without going into too much details, there are biological reasons. Rectal mucosa, anal mucosa versus vaginal mucosa. Right. And so it's fascinating to actually read about it. But the thing with Truvada is you literally have to be taking it every day, just like the oral contraceptive pill only works if you take it every day. And in certain populations, compliance is going to be lower than that, and sometimes much, much lower. And if you're a young woman who might not be sexually active but could become sexually active in the near future, it's not enough to say, yeah, I'll start taking it when I have to start taking it because it could be too late. So the trial was ended early because the interim findings were really remarkable. Among 2,000 patients, 0 cases of HIV compared to the Truvada group, not a placebo group, Truvada group. 16 cases out of 1,000 patients. So 0 in 2,000, 16 in 1,000. So they stopped it early because it's extremely effective and you don't have to worry about the compliance other than getting them to come back every 6 months. This is incredibly encouraging because, like I said, 500,000 people die every year. And even though it's declining right now and infections and deaths are declining, it's still the second or third leading cause of death. And we've talked about tuberculosis and COVID.
So while we're waiting for a vaccine hasn't come. This intervention might provide the same kind of protection.
It's exactly what I'm thinking. Like, I feel like we have spent 40 years, we have talked about a vaccine for AIDS and whether we could have a cure or a vaccine or whatever. And I'll be honest, like, as a young gay man in the 1980s, I always thought, 10 years is too long almost. But you still waited and you thought, okay, 10 years, we'll get it in 10 years. It took about 20 years or close to 20 years to get to a point where you have something approaching a cure. But that doesn't stop the spread, and there are a lot of people that don't.
How does it work?
Which this drug? Yeah. It's I think a capsid inhibitor. I'm overstating that. I've read it, but I don't even remember.
It's okay.
But it's a different mechanism. It's a mechanism that has been used in other ways, and I believe it will be used as treatment as well as prevention, but twice yearly. So you got about 150 million women in Africa that are at risk. The cost of treatment is going to be really high for them. This is a poorer population, but this may be our first chance to really eradicate HIV globally. Like, you can imagine now getting the reproduction rate for HIV down so low that you basically eradicate the entire disease from the world. Yeah,
that's incredible. Hey, thanks for sharing that. I hadn't seen that.
I was blown away by that.
Yep. So one thing I want to talk about, let me pivot now to another topic. This is a little bit different. It has to really do with social determinants. And I really want to tout this thing that's going on at Rush. Rush Medical Center, major medical center in Chicago. You got Northwestern and you got Rush, essentially. But Rush is really the safety net major healthcare system. Of course, it virtually runs Cook County, and it's sort of managing a large swath of areas of Chicago that have people who are most vulnerable,
Sort of like the Boston University, Boston Medical Center of Chicago.
Yeah, it's highly they're covering highly deprived deprivation areas and areas in greatest need, and I think they have the most visionary CEO in the country, Omar Latif. Omar's still young. Was a chief medical officer within the Rush system. I mean, his roots are actually taking care of patients. Wasn't trained as
I think he is a cardiologist, right?
No. He's in intensive care.
Okay, because he's a fan of yours. He's reached out to me.
No, he's great. Yeah.
He's a fan.
So I'm a big fan of his. So listen what Omar's done with his team at Rush. So they started thinking about okay, how are we going to improve population health? They really are committed to saying, what are we going to do? We shouldn't just be here treating patients, but we got to figure out some ways of actually preventing disease and improving things. And they look around in the communities that are crack houses and poor, like you said, economic deprivation areas and so forth. And they started thinking, well, we have a lot of vendors at the hospital, and we're outsourcing to multinational corporations to provide services like laundry.
Right.
So what if we worked with the community to help the community build the capacity to be able to provide some of these services to our healthcare system? So we're not just taking community benefit and giving charity to community, but we're actually building industry within our communities that are run by our community members, training people how to do it and putting them in a position to get jobs, create jobs, and to improve the quality of life for people around them economically as a central lever to improve health. And it's been extraordinary. I mean, just today, they're opening a linen factory. I mean, millions and millions of dollars are being spent by Rush and all the hospitals for these kinds of services. And what they discovered was there were people in the community who were willing to partner with them, actually own the enterprises, compete for the work. They've got to be able to
that's the way to
make
do
it at a certain level. But they were actually holding their hands and helping them to get there. And what he told me was that this thing is just going gangbusters. They built this thing. Now other hospital and healthcare systems, on competitive reasons, are looking to say wow, it's very cost efficient. It's a local business. We can also get our services from them. And they tore down crack houses. They helped provide capital to be able to start these companies. And again, they're owned by the community.
Yeah, so this is good because it's low-wage jobs in many cases, but it's low-wage jobs that lead to higher-wage jobs, and it also shows people that enterprise can be a pathway to freedom. It may not be
lower wage in the sense they can be given health insurance, they can be given
reasonable
wages. Yeah. Anyway, I was just so inspired by that.
That's a great story.
That visionary approach. They don't have to do that, and I hope it'll set an example for many other places around the country.
Yeah. So I wanted to talk. You reminded me I should mention the other issue around Vivek Murthy. I'll do that a little later, but I wanted to just talk really briefly about his announcement yesterday about gun violence as a public health crisis because, and we talked about him just last week about social media. Gun violence is one of these third rails that too many people are afraid to touch, and he almost did not get appointed the second time because of his earlier speaking about gun violence before his first appointment as Surgeon General. So it's a very difficult topic for a Surgeon General to want to tackle. But gun violence is a public health crisis, and that's what he came out with yesterday with the Surgeon General's advisory on making the case that gun violence is a public health crisis. He highlighted a lot of statistics, including the fact that as of 2020, firearm deaths are the leading cause of death in children and adolescents. I mean, just think about that, because the other leading causes of death are cancer, cardiovascular disease. We would do anything to reduce cancer in kids, and we would do anything to reduce deaths from cardiovascular problems, congenital heart disease in kids. But when it comes to gun violence, we really don't do a lot. Part of it is our instinct for the Second Amendment. Part of it is probably a fear of government in general. But for a lot of reasons, we have not come together to do anything of substance to fight gun violence. And so his advisory highlights the issue. It draws attention to the fact that we need more research, that we need to do more work about preventive measures, measures around social determinants of violence, as he describes it, measures around translational efforts, like how do we take things that we've learned and put them into practice, and to change the culture in communities to make protective measures so that children do not have access to guns. Remember, a lot of these violent deaths are suicides. in young adults and adolescents. So I thought one of the quote that he said in his video that was attached to this was, "Our failure to address this public health crisis is a moral crisis, and we must now act with the clarity, courage, and urgency that this moment demands." And we are this week 2 years out from Chris Murphy's bipartisan Safer Communities Act, which passed Congress and signed into law by President Biden. And it does seem to have had some effect on preventing people from getting access. It's on the margin. It's not big legislation, but it seems to have caused some change. And we are seeing some reduction in gun violence since that passed 2 years ago.
Yeah, it's still way too much.
Way too much.
We talked about the social media. Let me just hit down that for a second. He got a lot of blowback about that. The
about
question
social
was,
determinants of violence?
No, back on the social media.
Oh,
advisory,
yeah.
Because the question was, is the science firm enough? Is for some people
Yes.
is it beneficial? So I thought that was very interesting. Then it was also interesting. He follows right up with this. By the way, he was in Aspen also.
Yes.
And with this thing about gun violence, I'll tell you my reaction to this was, and we both have great admiration
Yes.
for him. I wondered if he should have waited till after the election. I'm not sure at the margin a Surgeon General announcement like this is going to fundamentally shift what's going on in the nation. I'm glad that he's digging into it, but it also becomes a political.
Yes, I can't. I'm
issue.
terrible with the politics because I could make the opposite argument and say that a lot of people think Democrats need to stop being afraid of this issue.
But they're going to vote for Biden anyway. Those people are voting for Biden.
That's probably true.
Anyway, I don't know. At the margin, there's some people who love their guns and are uncertain about Trump. This is just.
Yeah, I hear you.
I'm just saying the politics you're getting in the summer. It's just months to it. He just announced social media. Give 6 months. Now come out with a big thing.
So just in fairness to him and knowing how his office works, these are independently timed. These are developed and independently timed, and he probably has the latitude to say don't announce them on the same day, but not timing beyond that.
Anyway, I'm just saying, look, I think you could give kudos to the Biden administration for not bearing it, right?
That's right.
They're giving him independence and allowing him to do it. But I think there is some political risk in this moment where we're just months to November.
Yep.
And, this week is going to be very interesting on Thursday. This is going to drop on Thursday night. Next week, maybe we can talk about what the debate was like. But anyway, that was sort of my thought.
I hear you.
Hey, okay, let me pivot to something else I thought was kind of amusing. So there was amusing in a kind of funny way, actually. So JAMA Internal Medicine, one of the leading internal medicine journals, publishes a paper this week, Patient Navigation for Lung Cancer Screening at Healthcare for the Homeless Program, a randomized clinical trial. And Vinay Prasad takes off on this article.
We are not fans of him for a lot of things, but we also respect the fact that he's very bright.
First of all, he's very independent-minded, and many of the things he says are true and unequivocally true.
Right, but he's a contrarian. This is what he makes his career on, is finding things to.
But I don't agree with him on everything.
Right,
I'm sure he doesn't agree with me on everything.
Yeah.
And sometimes he's
right.
But this was very interesting. So he's bringing up this paper. I always am loath to criticize someone's paper because I know they spend a lot of time doing it. But he says, he talks about how this paper takes people who were ever homeless and randomizes them to an initiative to encourage CT screening for lung cancer or usual care. The result was, and I'm reading from his blog, if you get a push, the more likely you were to get a scan. But then he sort of goes on.
By push, just to be clear, what they're assigning them to is like having a navigator, sort of say, you should go for a scan. And these are people that come into the office. These are people that are not just a homeless person on the street, but someone who's already plugged into the system as a homeless patient in this clinic.
So I just thought this was funny because you see all sorts of different articles, and he's taking this article and he's sort of showing table one, characterizing. And there's a very needy, socially needy group, homeless group. And he says, imagine this population, ask yourself, what's the most important thing they need?
Right.
An apartment, a job, basic blood pressure control, work on existing ailments, perhaps a shower, a haircut, clean clothes, a hot meal. And 1 in 4 has a drug or alcohol problem. 85% are current smokers. Maybe they need some addiction medicine. He goes, and now these researchers are digging in and saying, let's get a screening CT scan. By the way, as part of an annual evaluation. Anyway, it just was a question, if you're a researcher and you're going to spend time doing things. And he's saying even if lung cancer screening works, it's contingent on rates of follow-up and a whole range of other things that are probably largely inaccessible to this group. So
I thought so. So you told me about this.
Interesting thing.
I hadn't seen it. It is in my field, radiology, the screening, and what I thought was the most important point he was making to me is just reminding us that we actually have no evidence that this actually, saves lives. Is the saddest part is that we're investing this much effort into something where the weight of the evidence is still equivocal.
Well, I thought the reminder also was, what are we studying and how important is it to people?
No, I get that. Yeah.
When we started in the Robert Wood Johnson program with this community-based patricia research, one of the first things we learned was, talk to folks that you're trying to help and figure out what's important to them. And, oftentimes you go into communities and you say, we want to do X, Y, or Z.
Yeah.
And they're saying, we're concerned about trash and rats. And,
right.
They're basic things that you can't get me to thinking about screening for cancer or my colonoscopy when,
I'm with you. I'm just saying,
food on the table every week.
I'm just saying, even for those that might say, but don't they deserve to live longer too? And wouldn't this be a good intervention? There really is no strong evidence that this even works, which is what makes it the most painful to me. We do an awful lot in medicine for which the evidence of benefit to the patient may in fact be de minimis or zero, and this is one of them.
Well, in this case, this was about getting them one scan. But look, you got to build up from the beginning. The fact that they could get them in for medical attention is a good thing. I do want to salute a group that's studying a very vulnerable population.
Fair. No.
But it amused me.
It does, particularly when you frame it that way.
And of course, he's a gifted writer. It was amusing. Anyway, if people want to take a look
I hear you.
At the paper or what he wrote, it might be worth a look.
So let me do quickly just about Murthy versus Missouri.
Murthy versus Missouri.
Right, which is the legal case. And by the way, a lot of people, when they say, every time I saw Murthy, I didn't realize it's actually our friend, Surgeon General Murthy. But one of the most important Supreme Court cases of this term was Murthy versus Missouri, which was attorney generals and a few other plaintiffs basically complaining to the government that the executive branch, the Biden administration, and that's where Murthy comes in because he's just one name among the long list of names, but he's the first one. Right? So it becomes Murthy, is basically suppressing the speech of people on Twitter and Facebook and other social media through the heavy hand of government by telling them you have to censor this and you have to censor that. And the ruling came back today with a 6-3 majority opinion in favor of Murthy, not on the necessary merits of the case, but on standing. And by standing, we mean that they felt that all the people that were suing, the attorney generals and others, that none of them were actually harmed by this. They were making a claim, but they had not harmed. So we haven't really clarified the First Amendment issues per se, but it has been rejected by the courts. Now, remember, this is overturning the Fifth Circuit Court of Appeals. So it's a very big thing. The government has been limited from what they can do because of the court cases that led up to this. 6-3 ruling, Amy Coney Barrett writing for the majority with Justice Roberts and the 3 liberal justices in the majority against, and I'm missing Kavanaugh as well, against Gorsuch, Alito, and Thomas dissenting. So it was just interesting. I just thought I'd bring it up because we're talking about...
but is it going to come up again because this is just about standing?
I mean, the issue will come up, but this particular case presumably won't, because if they couldn't find someone with standing for this case, they're not going to find it going back to 2020 to begin with. It'd be hard to dig somebody up for that. But the issue will come up again about how much can the government sort of prod.
This wasn't just about health information, though.
No, it's all about censoring, but it really was
about the
COVID.
Pandemic. Yeah, the pandemic.
Yeah. So it's just interesting for our listeners to know, because this is healthcare. This is about freedom of speech. I listened to the oral arguments on this case.
You did.
And to me, it's fascinating to do that.
You really are a policy.
Oh, no, I love this stuff. Yeah, I love the Supreme Court things. And it really was very compelling to me that there's a big difference between saying to Facebook, if you don't do this, we're going to figure out how to tax you more.
I'm just curious, what side of this were you on?
Oh, I was totally on Murthy's side.
So just, and people know that you're,
I feel
not
like
a Trump fan.
Not a Trump fan.
So when Trump comes into office, if he does, and he now exercises this power, won't you be concerned?
Same test. I mean, the same test should be put in place is there a legitimate threat? Is there actual harm being done to free speech? Are we taking away speech? Or is it within the right of government to use its power to, if somebody were to come to the federal government and say, by the way, this information is getting out there. It's harming people. We can connect the dots to this. We would like you to take down this type of information. I don't think that's unreasonable. And by the way, like, both sides make these mistakes, and we have civil litigation that has proceeded against Fox and against other companies over election denialism.
Well, okay, look, election denial, I think that there are facts. Some of the things that they were talking about, though, in the pandemic, again, if you take our reference to Vinay Prasad, he might say that there are things the government thought were true that maybe in retrospect may not have been true, or at least are controversial. And they were damping down the kind of public dialogue by making the kind of pressure, to not say certain things.
But at the same time, Twitter resisted, Facebook resisted. There's a lot of examples where they resisted. It was not the heavy, heavy hand of government. It was government saying, we learned about this. We think you should look at that. And then letting them make
And you and I both feel like ivermectin or hydroxychloroquine. I mean, there was a right and wrong answer to those.
Right. But
even today, some people will disagree
absolutely. With us. And even today on those things, there is a difference between taking down the tweets and putting community notes on Twitter up that say you shouldn't, that you should at least know this more information.
Yep. Hey, I know we're getting to the end. Just one other thing people might have seen in the news that kind of tweaked them was this thing about this sweetener, xylitol, and whether or not it was harmful. There was an article in the European Society of Cardiology Journal, the European Heart Journal, that looked at xylitol. Again, you see it in gum and different places.
I've had it many times in different products.
Well, I'm sure that not even noticing sometimes.
Yeah.
I think in toothpaste, other things.
Yeah.
In the title of the article was xylitol's prothrombotic and associated with cardiovascular risk. Now, some of the listeners may remember, I talk about it sometimes, that I published this piece in the Wall Street Journal in 2017 that they put this title on, why one cardiologist has drunk his last diet soda. And I had drunk my last diet soda, haven't had one since 2017. And at that time, I'd really looked at the preponderance of evidence about these sweeteners and was convinced that there was a fair chance that they were actually causing harm and perturbing our metabolic system, causing cardiometabolic abnormalities. And there's no evidence that anyone's ever lost weight on these diet sodas. I spent decades pounding these diet sodas.
Me too.
Trying to control weight and do different things. But there's not one bit of evidence that anyone who's taken that strategy has actually been able to better control their diet. I mean, it made sense. It's 0 calories. It should be good. Going all back to Tab, which was, awful tasting, but we used to drink it.
Totally.
My mother drank it all the time, to try to control weight. So this study I thought was very interesting because it had two pieces to it. One was an epidemiologic piece. One was a mechanistic piece. And what they did was, in the mechanistic piece, they showed that you could use a xylitol if you looked at indices of platelet reactivity. So the platelets are the components of the blood which help clot,
right?
And they can become sticky. And there's certain assays you can run to sort of look at the stickiness of platelets. And it seemed as if this substance could increase the likelihood that blood clots would form. And then they also looked in a large-scale cardiovascular epidemiologic study and an approach. And it was suggestive, again, hard to be causal inference. It's hard to say for sure, but there was some suggestion that people who had higher levels in their blood of xylitol. So this was good. It wasn't just self-report like I drink diet drinks, but actually people had higher levels where it increased cardiovascular risk. Look, this hasn't been settled science. This is a good journal. It's a reasonable contribution. I think in the absence of evidence of clear safety and of real benefit, people ought to be thinking more about water and tea and other things.
And again, you brought this up. We talked about this maybe a year ago, erythritol as well.
Yeah,
so
exactly.
A lot of the sugar alcohols might be in this category.
Saccharin, sucralose, all these things have had questions raised about them, and yet entire populations have been exposed. And for what? I mean, where is it really helping us? That's the question. I mean, look, we're all about decreasing sugar, especially high fructose, drinks and so forth like that. But the question is, does substitution with these diet drinks, is it a net benefit or not? Rather than getting off this stuff altogether and trying to find other healthier drinks. So anyway, I continue to be an advocate for people to think about alternative approaches which move them away from both diet drinks and from high fructose.
I gave it up for different reasons 14 years ago. And But for me,
and your life has been wonderful since.
Yeah, fantastic. But for me, the problem is I have all these protein bars. They all have sugar alcohols.
Yeah,
in them.
that's right.
All of them.
That's right.
So these are the
sugar
health
alcohols
bars.
are a whole nother issue. By the way.
But these types of things, xylitol, erythritol, no matter which one I look at, they have one of these types.
Oh, yeah. I was thinking about the mannitol. There was ones that actually blew up people's guts.
Different. No. I'm talking about
No, but
this.
the xylitol, you're absolutely right. These are the same things.
And these are in the protein bars. Like, we associate protein bars as being sort of healthy and healthful. I know that they're not. I actually worry about them, and there are certain protein bars that I know are healthier.
So this is like what we talk about all the time. If you've got a drug, you've got to go through all these sort of hoops to be able to show safety and effectiveness.
Yep.
On the food side, let alone all the supplements. We're going to spend more time on the supplements in the future. Howie, we've got to end. This is a great conversation. Why don't you end on a flu update?
Yeah.
What's going on?
We get a lot more information really quickly. So brief update. We still have no human-to-human transmissions. Tens of millions of birds in the U.S. have had the flu, the H5N1 bird flu. So 120.
Say that again.
Tens of millions. I think it's 90 million birds. 126 herds of dairy cattle in 8 states. And then there are sporadic cases in other mammals, including mice and foxes. 3 humans in the United States have been infected, but not from human-to-human transmission. 2 in Michigan, 1 in Texas. And there are anecdotes of other people with symptoms, but they weren't tested. And the new news from yesterday, which is really good news, is that Michigan is taking a much more aggressive effort at surveillance. Their farmers are helping this. The state government is helping this. And they're going to start doing both surveillance, seroprevalence, testing blood, as well as testing people with or without symptoms, and the animals, which is really good. So we got a lot of feedback from the last update. I wanted to respond really quickly to a whole bunch of questions. One, someone asked about the case in Mexico where a man died. And I just want to mention that is unrelated to this outbreak. That is H5N2. Have no more information on it. I can't explain why that exists, but it's not related to this outbreak, so it should not change our thinking here. Somebody else asked me, a friend had conjunctivitis. Should they be worried? Because they knew that 2 of the 3 men have conjunctivitis. So unless you have exposure to dairy cattle at this time, it is, and I mean it, it is next to impossible to imagine that this is related to the current outbreak. We believe that the 2 cases of conjunctivitis were from direct contact with infected cows and probably from their infected milk. Another listener asked about whether cheeses are a concern. Remember we said raw milk's bad? What about cheeses? If the cheese is made with unpasteurized milk, there is potentially heightened risk. So again, recommending avoiding it right now if they're domestic cheeses from potentially infected herds. Another listener asked about vaccinations. And here's another interesting thing that just we found out today. We do not have an H5N1 vaccination program in the U.S., but just this week, Finland became the first country in the world to begin vaccinating high-risk humans against the disease. So we're going to learn more about that over the next few weeks and months. And the last question that I got for today, a listener asked me about pasteurized milk, which we've talked about. I can't say that there's 0 risk, but it's got to be really close to 0 risk because more than 99.99% of all viral particles are eradicated through pasteurization. And our digestive tract and our other immune mechanisms do a pretty good job to begin with. So presumably that's enough. But I think we have to have humility about this, just like we did with COVID. We got to watch it. We got to see what's going on. But at the moment, no cases from pasteurized milk. And one question not being asked is, what about meat from infected cows? And we don't have an answer about that at all. So if I leave you with any good news on this, it's that I believe we're starting to see a major mobilization of scientists, public health workers, states, and farmers to start to wrap our hands around what's going on.
That's good. I think the public largely is still
in the dark.
In denial, really.
Yeah, and in the dark. I don't think we have nobody coming out with regular pronouncements from the federal government. I think I've seen...
So what's your guess here? Is this going to blow big, or you think we'll get over it without really...
I think it's going to percolate for a while, and whether it's 3 months, 3 years, or a decade, I think at some point it becomes a problem. And I think the best thing we can do is learn as much as we can right now and be prepared so that if there is human-to-human spread, we know how to contain it quickly.
Uh-huh. All right, great. Thanks for the update. I continue to watch this. You've been listening to Health and Veritas with Harlan Krumholtz and Howie Foreman.
So how do we do? To give us your feedback or to keep the conversation going, email us at health.veritas@yale.edu or follow us on any of the many social media out there.
Yeah, and we want to hear your feedback. Anyone's got any questions, you can see Howie's answering questions here today. By putting up comments, it helps people find us. We really appreciate that.
Yeah, and if you have questions about the MBA for Executives program at the Yale School of Management, reach out via email for more information at som.yale.edu/EMBA.
Health and Veritas is produced for the Yale School of Management, where we are today, and the Yale School of Public Health. Thanks to our researchers, Ines Gil and Sophia Stump, and to our producer, Miranda Schaefer. Just married. Congratulations,
Miranda.
Yeah, well, that's terrific.
Thanks very much, Harlan.
Talk to you soon, Howie.
Talk to you soon, Harlan.